Good morning, everybody. I am very excited to be here this morning and to welcome Dr. Mandy McCorkindale to our webinar, and welcome to all of you. This is a person and a program and a very close to my heart, because my original exposure to integrated behavioral health was at the VA in Little Rock, and I was working on the inpatient unit, and they said, well, go to primary care. I was like, what am I supposed to do there? And they were like, well, just see patients, build relationships. That was so I began Googling. That was in 2009. I ended up getting some training at the VA. It ended up being called PCMHI, Primary Care Mental Health Integration. And so we started our program and learning along the way. And the VA is very unique in that it is a population health program. At the time, I didn't really appreciate how that took away one of the barriers, which is how do you pay for a program like this? But the VA has had an initiative probably since 2007 or 8, where they have provided services in the system. But along the way, Dr. Mandy McCorkindale was in our system, and we ended up talking, and she was a perfect person to join our behavioral health integration team at the VA, and got to know her, actually got to hire her and bring her to our team. And so we got to work together for a little while. And then when I had situation change and I left the VA, then Mandy assumed leadership of that program and has continued to rise in leadership at the VA. And I'll let her tell a little bit more about that. But I'm very excited to hear about what's happening in the VA. The model is really a standard setter and has provided a lot of our evidence for integrated behavioral health. And it's done in different areas and populations. And so for Mandy to be able to share with us the VA model, which uses various types of the model, the VA program, which uses various models that we learn about. And so we're excited to have Mandy here as my friend and as my colleague and as a true leader in our field in Arkansas. So thanks for being here, Mandy. And you were telling us a little bit about your history of how you even got into integrated behavioral health. And that's interesting, as well as what's going on with your program. So welcome. Thank you for being here, and look forward to hearing more from you.
Thank you. Thank you. I appreciate that. And it's great to be here. I have, as I was telling Patty and Kim before we really got started, I've been able to attend some of the sessions that you guys have, the meetings, the gatherings, when we were able to do that in person. That was awesome, but it actually makes it even more accessible since it's by video now. But you know, as I was sharing earlier, I'm a native Arkansan. I'm from Arkansas, so I have so much appreciation for what you all are trying to do to have this integrated network and to really get information out across the state about how to integrate into the medical settings, particularly into primary care. I know it's a heavy lift, especially when you're contending with pay sources and all of those challenges. And so I hope that some of what I can provide to you today will be helpful. I'm not monitoring the chat box, so y'all feel free to just say hey and speak up, unmute yourself, ask questions. Kim's also gonna interrupt me if there are questions in the chat box. So let's get going. So Patty Robinson and Jeff Reeder are kind of pioneers in integrative care. Patty did some teaching at the school where I did my graduate work in Springfield, Missouri at the Forest Institute. But you know, this PCBH model is not merely to provide direct patient care, it's also to improve the delivery of healthcare for all problems and all people within the primary care setting. And I think that this is such an important, like, overarching vision and mission to be aware of, is that it's not just about providing mental health care, but it's about improving the healthcare system. So what is the VA model? It's a lot of things, but it can also be very, very confusing. In this world that we are navigating, we have a lot of different, it's complex. We have a lot of different words. A lot of the words have different meanings. So what is co-location? What is integrated? What is collaborative? What is consultative? It can get really confusing. And as different authors will write about the same thing and call it something different. So that makes it really challenging. We're going to talk some today about open access and scheduled visits, and how do you have that? How do you navigate that combination of keeping people busy but also being available? Behavioral health consultants. I'm glad to hear you guys already are using that phrase, that title, because it is especially important. It takes out, it removes some stigma of seeing a mental health provider or seeing a psychologist or a psychiatrist or a social worker, which social workers, like that title elicits so many different meanings for people. So using the phrase, using the title behavioral health consultant makes us all a little bit more overlapping. Everybody has their special skill set, but it's an important role, I think, particularly for primary care. 30-minute sessions. I'm not going to do a deep dive today into how to do a 30-minute session, but we are going to talk about that. But that's an important aspect of this model, is being able to see a patient in a half an hour. And then lastly, like, if you've seen one VA, you've seen one VA. So you may be up in the northern part of the state and have some familiarity with the Fayetteville system. Their PCMHI program looks much different than the PCMHI program here in Little Rock or in Shreveport or in Memphis. So it's all different. Although the VA has done a really great job back in 2017-18 of rolling out a competency-based training to all PCMHI programs and providers. So we're trying to really get the programs in line to have fidelity to the PCMHI model. But that, again, that's a challenge, that's a long haul, but the training is there, which is super helpful. So just kind of the basics of what is primary care mental health integration. And here in Little Rock, we actually refer to our program as primary care behavioral health. I think that helps to destigmatize mental health. People are a little bit more likely to be willing to be handed off from their primary care provider to someone on our team. If we're referring to our services as behavioral health, especially in cases where maybe we are we're being asked to work with a patient related to their diabetes management or helping them with weight loss or something like that. They don't want to see a mental health provider for something like that. But just to kind of, talk briefly about the VA's model. So we are set up with PACT teams. So this patient aligned care teams, similar to the medical family home. Is that what you refer to it out there in the non-VA world? So this is a team-based approach to care with consultants providing education and support to the treatment team. The PCP remains the lead and works alongside an interdisciplinary team. So our teams are made up of usually the lead is either an MD or an APRN or a physician assistant. Then there are RNs and LPNs directly on that teamlet. And then through like ancillary or augmenting services, the PACT also has a dietitian available, a pharmacist, a behavioral health provider, sometimes so medical social workers that can help with things like advanced directives. And then they have a pharmacist. So basically it's, you know, the main teamlet plus, I think of it as like additional spokes on the wheel that they can easily access on the same day that the patient is there seeing them. We also use a stepped care approach. And so the way that I think about this is within mental health, the behavioral health consultant serves as kind of like the PCP for getting a patient connected to mental health care. So they're doing a functional assessment, but then they're also thinking about, you know, is this problem or is this presentation something that I can work with here in primary care? Or do I need to be referring this patient on to a specialist? And so within the VA system, we have PTSD programs, we have specialty or general mental health, we have substance abuse programs. So sometimes the presenting concern may be something that the behavioral health consultant can work with directly in primary care. And maybe they have somewhere between 1 and 4 or 5 sessions with the patient, and then they refer them on to specialty mental health. So I talk about it like, just like if you came in to see your doctor for an ear infection and they treated you with a couple of rounds of antibiotics and that wasn't clearing up your ear infection, then they would refer you on to an ear, nose, and throat doctor, a specialist who can help. So it's kind of that same idea. Also, you know, working here in primary care, having behavioral health in primary care really improves accessibility to behavioral health treatment. And, you know, patients show up in primary care and they're more likely to talk to their trusted primary care provider about whatever might be going on for them related to their mental health concerns or mood or that sort of thing. And so having a behavioral health team located in primary care really helps to ensure that, you know, initial point of entry. We also get to serve as physician extenders. And so there are so many things that primary care providers have to cover in a very short amount of time. And so, you know, when I work with especially new PCPs, I talk about, you know, if you have a patient who's coming in and they are telling you about, you know, the death of their spouse or you know, something that's going on that's really more mental health related, you have the option to say, you know, that is really important, and I want to get you connected to the right person who has the expertise in helping you with that concern. And we actually have that person down the hall. So if you're willing, as soon as we finish our visit talking about your diabetes and your hypertension and all the things that you have to cover in that visit, then I can hand you off. I can get you connected to that behavioral health provider. So then along those same lines, we offer that two-way feedback. So then after the behavioral health consultant has seen the patient, they then provide that feedback back to the PCP about how that visit went, you know, just a short 2 to 3 minute at the most kind of recap and what's going on. but also then, you know, in terms of being an extender, if it's identified that maybe a patient needs some medication, maybe they are really having a lot of trouble sleeping, or maybe they have used an SSRI in the past that has been helpful, but they didn't talk to their PCP about that, then we can communicate back and forth with the PCP and to help kind of provide that, getting that patient connected maybe to those medications that they might need, or maybe referrals to other services within our system. So we also use brief solution-focused therapy, and this is typically and hopefully in most cases in the context of a 30-minute visit. 30-minute visits are really hard to accomplish, like all the things. So, you know, I've always told my team, like, okay, if it runs into 45 minutes with all the screeners that we have to do and all the things, you know, that's okay. But, you know, generally speaking, we're trying to see patients within just a half an hour. And part of that has to do with availability and scheduling. So, you know, if you're going to receive a warm handoff from a provider, you don't want that patient having to wait in the waiting area for an hour. So having shorter visits allows for you to be able to have that accessibility to meet that patient who's being handed off to you. So we use a population health approach focused on prevention and early intervention. I mean, the whole model is set up under that idea that if we can reach patients before their symptoms are severe, when things are in the mild to moderate range, then we can prevent the need for higher levels of care, for specialty care, for symptoms to exacerbating to you know, levels that might require something like hospitalization. And we do a lot of work with you know, lifestyle choices. I know, you know, we don't get to do quite as much of that, I think, here in the VA, but I definitely can see, like, outside of the VA system, I know that funding sources are being tied to improvements in specific diagnoses like diabetes and hypertension and that sort of thing. And that's where behavioral health consultants can really have an impact in revenue recovery, in improving like those chronic health conditions. So we can work with patients on behavior change plans using things like motivational interviewing. And then here at the VA, we have like a whole health model or approach that's really focusing on like what's important to you in your day-to-day life, and then how can we target that and develop plans to get you to your goals. Any questions so far?
I had one question. My question is, one of the things that you talked about was the people show up for primary care. Have you noticed, is there any problems with making referrals and people keeping those appointments? Because that's one of the things that I think that we see outside of the VA, we see is a lot of times when someone presents in primary care and there is a referral made, it's hard to get someone to show up, excuse me, for those specialty services. What's your experience with that?
Yes, and I'm actually, that's a great question, and I am actually going to touch on that, but to answer that now, so the research has shown that if a patient meets the provider who they're going to see for their mental health or behavioral health treatment on the same day that they are there seeing their primary care provider, and that primary care provider is endorsing this person as someone that is trusted and is a subject matter expert, and they actually meet the person that day, even if it's just for 5 minutes, they are much more likely to show up for that mental health appointment later. So I always tell my team, you know, sometimes we get slammed and you know, there be a patient that's walked over to the area where you know, our team primarily function, and it is kind of like a stop what you're doing and go meet that patient, because that connection, just that 5-minute meeting, really increases the likelihood that they're going to follow through with that follow-up appointment. So yeah, great question. I don't have the stats, you know, I don't have my hand in the literature, the most recent literature related to that, but there has been a lot of studies that have shown that patients are significantly more likely to show up for that initial appointment if they've met the person that same day.
Very helpful. Thank you.
Sure.
I had a similar question, and it's kind of maybe the inverse. And the question is, for the non-VA system, in particular in Arkansas and other places, appointments can often take months. And even with urgent cases, you know, I hear cases where suicide risk or severe mental illness, or when a PCP actually has a patient engaged, which is hard because of stigma, and they're ready to do the handoff that's warm, getting the appointment is very difficult because of the question is about access, capacity, and availability. And so I'm curious for the VA system, you know, what is the gap or the non-gap for both access and availability to get appointments? And when you have challenges where there's a large delay, how do you deal with that to keep the case engaged?
Sure, great question. So that is one of that issue is why the PCMHI model exists within the VA, because this model, this team or program within the VA system is set up to allow for access. So for example, I would have a provider who might have all morning, no patients scheduled, and then in the afternoon have like 4 patients scheduled. So that provider is available through the morning for any handoffs that come from primary care. And then of course there's another provider who's available in the afternoon. And then also as a manager, I was constantly ensuring that their clinic grids were not booked out so far that they didn't have space to follow up with that patient later. Of course, you know, we function within a system where we can refer patients on to specialty care. So that suicidal patient that you know, in that example, we would be trying to get that patient connected to specialty mental health. And we would continue to follow them until they are able to get established there. So, you know, it might take a month for them to be able to get an appointment within specialty mental health, but the PCMHI provider would then see that patient weekly, you know, have some kind of brief contact, 20 to 30-minute visits weekly until they are able to get them established with specialty care.
Okay, that's helpful. One last question, then I'll let you go on. I think to clarify, it sounds to me, tell me if I've got it wrong, that the VA system you have is more like a staff model. So you have a captive integrated model to, in essence, have the co-location or connection to both physical and behavioral health. Is that fair, accurate, or way off?
Yeah, I mean, you could think of it as like a staffing model, and which is essentially what the stepped care approach is, you know, if we can manage this patient's care right here in primary care, you know, whether that's, you know, assuming like a mild to moderate depression, you know, something that is responsive to some interventions like behavioral activation, you know, specific goal setting and something that they can work within that setting, then they wouldn't refer that patient on to specialty care. They wouldn't refer that patient to the mental health clinic. They would have 2-3 visits, and using measurement-based care, you know, really screening, ensuring that the patient is, that there are improvements, and then they may, just like you would if you saw your primary care provider, to figure out which hypertension medicine is the right one for you. You may have 3 or 4 visits to tweak that, and then once you're stabilized, then you discontinue, you know, regular visits. Does that make sense?
Yeah, perfect. Thank you very much.
Okay. All right.
We also, excuse me, we also had one more question in the chat. And the question is, what is the ratio of behavioral health consultants to PCPs?
So we have about 26 PAC teams here, and our team currently has availability for, all the positions are not currently filled, but about 10 behavioral health providers to 26 PAC teams. Although with the pandemic, we have expanded to be able to serve all of the outpatient clinics that are associated with Central Arkansas VA system. So we have 8 outpatient, community-based outpatient clinics. And so because of being able to use phone visits and video visits, our team is really being able to like provide services across most of the state. Yeah. It does require, I have to say, you know, having managed providers who work in those outpatient clinics, so 1 BHC to say 5 PAC teams within an outpatient clinic, it is really challenging to do this as a one person within a clinic, because managing that balance between availability and productivity was really, really tricky, because you want people to be seeing patients, but you also need them to be available. So actually the pandemic really opened us up to be able to provide more support to those providers who were like a one-man shop out there, you know, in Mountain Home or in Conway or wherever. They then were able to get backup because the other providers on our team were able to contact patients through video or phone visits. That's a whole nother talk I could get into. Okay. So what are some of the ingredients? So, you know, the focus of my talk today really is to get into, you know, how have we found success in implementing this model within this VA, and so that comes in a lot of different ways. Just to start off, the culture of primary care. So it's really important, and this is in the literature and all the books, all the Patty Robinson, Jeff Reader type books that are out there, but physical space. It's very, very important that the behavioral health consultant be like embedded within the area, the physical space of the primary care providers. So like when I did this work in the Air Force, they had workrooms, and I think probably y'all have this experience in your clinics, workroom areas where nurses and PCPs are all have like computer stations and a shared workroom, and then exam rooms where they see patients. So ideally, you have that behavioral health consultant working from that workroom. because that is how conversations are generated. That's how you're able to provide that consultation, you know, those sort of curbside conversations where maybe you're providing the nurse or the PCP with some guidance about how they can actually intervene or manage behavioral health type questions. So not all patients have to be referred to the BHC. Sometimes as a consultant, you're there to just provide information and education. So it's really important that the physical space is set up conducive for that. Another important aspect relative to the culture is accessibility. And so kind of number 2 and number 3 go hand in hand. So you've got to be accessible, and you have to you have to say yes to everything when you're really developing a program like this. So ways in which we made ourselves accessible were through a cell phone, one cell phone number that they could call and they would get whoever the walk-in provider was. With Skype and with Teams now, it's even more easy. I don't think anyone calls the cell phone anymore. They just reach out via Teams. So we actually have teams that are set up where they can send a message to all 5 or 6 of the behavioral health consultants, and then whoever sees that message first picks up that referral. So you have to be very accessible, and you have to be very responsive. And, you know, as we set up programs, particularly in the outpatient clinics, I told the providers that I worked with, like, you just have to say yes to everything. And then once they have gained an understanding of what your role is on their team, once they know that you are going to be helpful, then at a later point, if you need to set different types of parameters, you can do that. And actually, our team here is going through those growing pains now. We said yes to everything, and now a lot of the team members have changed. We've had some people that have left, you know, the team, we've had people out on maternity leave. So that has created this, you know, oh gosh, what do we do? We've got to say no. So how do we say no, you know, in certain ways? And so if as you're building a program, it's just very important to say yes and be helpful. And that helps to get their buy-in to what you're doing. Very important to know your stakeholders and the system. So, you know, I talk a lot about leaders, as I have here, leaders with a capital L, and then there are leaders. And so, of course, the leaders are the people who are identified in a job that makes them a leader. The chief of primary care, the chief of mental health, the chief of staff, all of those people who are in administration and who are stakeholders have a seat at the table. But when you're actually, you know, really trying to implement this model of care, it's important to identify the people who are leaders within the front line, people who are working there every day but serve as leaders. And so, you know, as Patty and I really started trying to grow this program back in 2015, 2016, this meant a lot of conversations with nurses. And I tell the story of Tony. So I was using an office that the phone number was associated to one of the nurses. His name was Tony. And like in Outlook or wherever, like that was the phone number that if people were trying to get a hold of Tony, they would call that number. Well, Tony had moved to another office but had not changed his number. And so I would get all these phone calls that were for Tony, and I'd be like, now Tony who? Okay, yeah. And so then I would be like messaging Tony, or finally like started walking over to where he was, like his new location, to relay messages to him. And so that's like how we got to connect, and for me to be able to to solidify this relationship with him. And he was a nurse who'd been around here forever and ever. And so as he learned more about what I did, then he started referring more patients to me. And so then I said, hey, Tony, would you mind in your next nurses staff meeting, would you mind like just talking about like how I've been helpful and, you know, what we've done together? And so then he was spreading my message. And so like it, you know, it's people like that. Those are the leaders who are really going to be the ones as you're developing, you know, growing a brand new idea like this, getting those people to come on board and do that messaging for you. So also, you know, we kind of developed a slogan. We are your behavioral health partners. And I tell that to, you know, every new primary care provider coming on board. We're your mental health people. You don't have to know all the things about mental health. We're the people that you can refer to. So if you have a question about mental health, or your patient has a question about mental health, you don't have to try to figure out, well, who was that psychiatrist they saw, or do I send them to 3L, whatever 3L is? Do I send them to here, there, wherever? Don't worry about that. We've got all of that. So we are your behavioral health or your mental health partners, and having that very simple messaging helps people to come to rely on you. And that's how you capture those referrals. One of the other things that I observed, and Patty will recall this, but so we were trying to figure out, like, there were always like kind of a group of PCPs who were like very resistant to sending patients over to us. And then we had some PCPs that were like totally on board with sending patients to us. And, you know, what was the difference there? And actually, I think it might have been the chief of primary care at the time who helped us to identify that, you know, the background and the training programs that physicians come from is going to have a huge influence on their experience of utilizing a team. And so, not to pick on any particular family medicine versus internal medicine trained, or, you know, even people who trained maybe within the military system versus those who didn't. The background and training of medical students and residents is super important in understanding the role and the value of taking a team approach. So that's something to be aware of. If you're like, how come I can never get so-and-so to send patients over to me? They want to just do their own thing, or they want to, in our situation, enter a consult. It might be worth looking at what is their training, what is their background, because that can sometimes answer those questions. Any questions at this point? All right. So, understanding the role, the ingredient of our staff, or our people who are working within this PCMHI model. It is very important that sometimes you inherit a team, sometimes you build a team. It is vital that the people who are working in this model understand the rationale for it and also want to do it. It's not for everyone. And so, you know, the staff have to really believe in and embrace a population health approach, a stepped care model They have to be willing and interested and engaged in the idea of brief treatments, doing functional assessments, and developing really clear action plans, because it's hard to hand a patient off to some higher level of care if you can't demonstrate that the patient hasn't done the things that you and the patient have worked together to as your interventions. So also it's important that, we've talked some about same-day access, that, kind of striking while the iron's hot. The patient is there, they're interested, engaged. And also, so it's important that the staff really embraces that as well and are willing to stop what they're doing and take care of that patient. Training in the 5 A's model, being able to conduct functional assessments. This is a huge mindset shift, because in most of our training programs, our graduate training programs, we're really focused on diagnosing and, getting into the DSM and figuring out, is it major depressive disorder, moderate with, is it recurrent, whatever, like all the words. But really in this model of care, certainly you need to have background, you need to have understanding of the DSM, but we are really focusing on what is important to the patient's daily living. And so when I train interns, sometimes they'll get all, well, I don't know if this might be hypomanic. And I'm like, okay, well, let's just really look at what's the problem that's going on right now. Of course, we need to have that in the back of our mind, but let's try to focus on how is this problem interfering with their daily living. So we teach the 5 A's model, and we use the functional assessments.
I was wondering, we have a question. I don't know if you could talk a little bit about the 5 A's model and what that is and what that consists of, because some of us on here may not be working in clinical settings. Yes.
Yeah. So the 5 A's model is assess, advise, agree, assist, arrange. And so basically you are doing a functional assessment that involves, like, of course, you're looking at what is the presenting problem, but you're also looking at, like, how is it interfering with certain areas of life, work life, family life, physical health, that sort of thing. And then you are providing some sort of advice about, like, a direction that we could go. Then you are agreeing together on, using a patient-centered approach, agreeing on, well, here's like the menu of options of what we can do. Can refer you to the pharmacist to talk about a medication. We can develop a behavioral change plan. I could send you to the PTSD clinic or whatever. But then together you're agreeing. And then the most important part, though, is, like, you're providing some sort of intervention, and you're creating an action plan. And that action plan is what the patient is then going to go and do in their daily life. And then come back to you in 1 to 2 weeks and talk about how did that go, and was their action plan successful, or where did they run into problems? And so then you're troubleshooting that. I could go into a lot more depth about the 5 A's model, and if at some point you guys wanted me to do a presentation just on that, I could definitely do that. But it's really focused on, instead of taking, like, this whole family history, you were born in 1962 and your parents divorced and blah, 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 and you have 6, right? You're not doing that whole psychosocial assessment. You're really focusing on what's the problem and how is it impacting your daily living right now. Also important to understand that the staff understands how we are being measured. And this was a really tricky one for us at first, because productivity and sale metrics and SHEP scores and all of the things that we're being measured on now, like was just coming on board when Patty and I were really starting to implement this. So she'll remember some of those challenges, I'm sure, but now it's actually a thing that our team really craves and asks for. They want to know how they're doing on certain metrics and measures. And so, you know, if we're not measuring, then we're not really knowing where we're going. So the way I think of it is we have a vision of, you know, how we want to, what sort of services we want to provide. What is this? We have a vision of this stepped care model. We have a vision of population health. We have a vision of how we're going to roll this out. And the measures is what helps us to know if we're moving in the direction of our vision. And so it's important that your staff understands that as well, and that they're on board with you know, paying attention to those numbers and how they're guiding us in our decision making. We also use measurement-based care, which here at the VA, that means that every veteran who comes into primary care gets screened for depression, PTSD, suicide risk. We also do an anxiety screener. And so there are a lot of screenings that occur. And those numbers then can guide us in helping us to know, like, which patients are maybe appropriate for primary care and which patients probably need to be referred on to specialty mental health. The other important aspect of measurement-based care and using numbers to guide your practice is that you're having that conversation with the patient where you're saying, you know, today's our fourth session, and, you know, we've been doing this PHQ-9 depression screener. Your scores have gone from 19 down to 16, back to 19, and now today you're up to 21. You know, this is kind of telling me that maybe what we're doing here isn't working. You know, so you're using the measures to have a conversation, again, guiding what your vision is towards the goal for the patient's goal. And then that may be the thing that tells you it's time to refer on to a higher level of care. You can't cover everything in a 30-minute visit. Patients may need a 60-minute visit. They may need a 90-minute PTSD protocol. So, you know, using measurement-based care can be a tool that really helps you navigate that 30-minute visit.
I have a question. As far as when you're screening them, when are you screening them in the process? Is this maybe in the waiting room as they're preparing for a visit? Is this when they're in the exam room and possibly the medical assistant or nurse is utilizing the screeners? Is it a BHC coming in and using the screeners? Where in the process?
Right. So pre-pandemic, we were doing it on clipboards, on paper. They checked in for their visit. They were handed a clipboard and they filled out the measure. Now, of course, over the past year and a half, we don't see as many patients face to face, but fortunately the VA has created a lot of tools that can help us with that. So initially, you know, some of those video visits did involve the provider reading through the screener, which takes a lot of time. So, you know, of course, you're going to go over a 30-minute visit, but now we have some online digital, we can text message the screener to them and the patient can complete that via text and it comes back to us and then it populates into our electronic medical record system. So we've also used secure messaging as a way of having them complete those screeners prior to the visits. Okay, so got about 9 minutes left. Okay, so this is kind of really, this is pretty much the last slide. Just talking about like the important ingredient of who is the behavioral health consultant. So I already mentioned, like, it's really important that the people who are doing this kind of work want to do this kind of work. If you're the kind of person who really craves and needs a scheduled day that's very predictable, that you walk in at 8 o'clock in the morning and you know that, you know, you're going to have a patient at 9, 11, 1, 2, and 3, and you're going to have a full lunch break. And, you know, like, if that's like just your personality, this is not the best place to work. This is a really fast-paced environment, but it can also be a very slow-paced environment. It just sort of depends on what's going on that particular day. Things are changing all the time. So it's important that the BHC is somebody who can handle and embrace unpredictability. Very important that you don't have to be an extrovert, but there is an extrovert quality that you have to assume in being a behavioral health consultant. So I consider myself an introvert, which means, like, by the end of the day, I'm just exhausted and I'm just like done. I don't talk to my family. but you know, you have to be willing to put yourself out there. You've got to, you know, especially in the beginning when you're growing a program, is you've got to have that personality that, you know, you're approachable, that you're communicating, that you're, you know, really, that you're very much a team player. Also important that you can't be too hung up on, like, your own sense of identity as a professional relative to whatever long, extreme number of years you've gone to school, and you've gotten this like super important degree and you've done all the work, and then somebody's like, yeah, but you're just a social worker. We need a psychiatrist for this patient. So many times that has, you know, that has been a challenge to navigate. And social workers, I think, are like, I don't know how many social workers we have out here, but they get the most confusion, and people have their like preconceived ideas of what is a social worker. And in this line of work, social workers and psychologists are really pretty interchangeable. I mean, if you have a background in, you know, understanding medical terminology, and you've been trained in some evidence-based interventions, you understand brief solution-focused therapy, psychologists and social workers are the same. But oftentimes we'll find that PCPs, they think that their patient needs, you know, a psychologist or needs a psychiatrist, not a social worker. And so many times I would have the conversation like, no, she can do the job just as well as I can, you know? So like being able to say, okay, this person just doesn't know. And we have to like be able to check our egos at the door. Very important. I always tell people when I'm hiring someone new, they're like, I've never done this kind of work before. Exactly. You and every single person who comes into this environment, like we didn't get trained to work in this setting. So as long as you are willing to learn and you're open to the opportunity, then, and you can think on your feet, then everything else is teachable. And I have 5 minutes. So really, like, what is the most important ingredient? You know, I say it's you. Because what we know about therapy and success in therapy, it's the Therapeutic Alliance that is the most important change agent. And so being able to build rapport quickly and be authentic. So, you know, like one of the things that I do when I meet someone for the first time is I'm not looking at the computer. I'm not looking at the papers or the clipboard or the whatever. I introduce to them, you know, what my role is here, because they don't a lot of times know. And then I am giving them undivided attention and hearing and really listening to them for at least 3 to 5 minutes. And you would be surprised how far 3 to 5 minutes can go in the healthcare setting these days. And, you know, we are asked to do so many things, and our healthcare providers are so divided, and they have to accomplish so much stuff in the electronic medical record. But that rapport that you can build very quickly just can make all the difference in whether or not that patient's going to come back again another time. Also, it's really important, as I mentioned earlier, to really have a strong foundation in mental health diagnoses and being able to ask the right questions quickly. So you're using a lot of your intuition, but you know, so we don't want to always jump to, like, the hypomanic example I gave earlier. Like, we don't always necessarily want to jump to that, but we want to have that in the back of our mind. You know, we don't want to dismiss it completely. And finally, having a patient-centered approach and following with what matters most to the patient. So many times a PCP will refer a patient over to me because they have, you know, depression or whatever. But what I find when I talk to them and get to know them is what matters to them is that their house is being foreclosed on, and, you know, their dog died, and, you know, whatever psychosocial thing might be going on in their life. And although that might be creating depression, if we can help them navigate, you know, some of these life things a little bit better, do some problem solving, then, you know, that's what makes a difference. So being very patient-centered. All right, that's what I have for you today. Any other questions or thoughts?
I just wanted to say what an amazing presentation and description of what's currently happening in your VA program right now. And I'm just so grateful that you and Dr. Gibson brought this presentation to us today. And wow, just the amount of time, effort, and persistence, right? I heard you talk about to get this program really off and running and some of the struggles that happened. Let me ask, I know we're down to just a minute or so. Does anybody have a burning question that they'd like to ask? We're getting lots of positive feedbacks in the chat saying great presentation, fantastic information. People have learned a lot.
Awesome. I'm gonna open the chat. And y'all feel free to reach out to me. My email address is there. If you have questions, you know, anything I can help with, I'll be glad to. I'm not currently working in primary care now. Early part of May, I stepped into the role of Chief Psychologist here in Little Rock. But I do still see some patients there, and I can also connect you to their team too, if you have questions specific for them.
Awesome. Thank you for sharing your contact information with us. And it is 9 o'clock, so we want to be respectful of everyone's time. If you do have a burning question that comes to mind after today's presentation, please reach out to Dr. McCorkindale with her email here, or you can email Dr. Gibson or myself, and we will try to get those questions to her. Thank you for your time today, and we'll see you in October.